So our first speaker tonight is Cheryl London. Dr. London is a faculty member at Cummings School of Veterinary Medicine, and we're very pleased to have her join us this evening. She was recently appointed the Engen Dusty Professor in Comparative Oncology. This is an endowed professorship made possible through a special program, the Professorship Partnership Challenge Program. And this was a gift from Anne and Travis Engen in memory of their dog Dusty, who died of bladder cancer. And I just have to add, Anne Engen has been a champion for comparative oncology at Cummings School for many years. Really, without her interest and support, the program for our clinicians and our clinician scientists really would not have flourished or even gotten off the ground. Cancer is, as we all know, a terrible disease. It touches all of us directly through loved ones, whether those be human loved ones or our animal companions and family members. Comparative oncology is a field that brings together researchers from veterinary and human medicine to advance our understanding of cancer biology and really optimally to improve our ability to diagnose and treat cancer in both animals and people. Dr. London is a great example of what we call One Health. She not only works on animals, but she works very closely with human cancer investigators, and those are spread across the city of Boston, including at the Broad Institute, the Dana-Farber Cancer Institute, Boston Children's Hospital, and MIT. And that's just within Boston. So she has many other collaborations with institutions and industry partners really across the country. Dr. London earned her DVM at Cummings School of Veterinary Medicine, so we're very pleased to claim her as an alumni. She completed her residency in medical oncology at the University of Wisconsin-Madison and received her PhD in immunology at Harvard University, where she was also a postdoctoral fellow in the Department of Pathology. So please join me in welcoming Dr. Cheryl London.
Thank you very much for that introduction, Dean Kajiver. And welcome, everybody. Good evening. So I'm a veterinary medical oncologist, but I work in the field of human oncology many times. And how many of you have experienced a loved one with cancer? Raise your hands. Most of you. And how many of you have heard through the news of these amazing breakthroughs that we're having these days? We're going to cure cancer in a number of years. Yes. So the reality is actually not so great. So it turns out that even though there are some blockbuster drugs that have really changed the landscape of how we treat cancer, many patients don't benefit because the failure rate associated with cancer drug development is extraordinarily high. If you were to guess about 50% of drugs fail, you would be wrong. It's closer to 90%. So 90% of the drugs that enter human clinical trials generally are found to not work, and they fail. And if you actually look at the benefit that those patients that get those new drugs that have actually made their way through get, it's actually fairly small. So there was a recent analysis that was done of all the new cancer drugs that were approved from 2002 to 2014. And it turns out if you take the aggregate of all the patients that received those new drugs, patients only benefited by 2.1 months of increased survival. So although there are amazing breakthroughs, many patients just aren't experiencing the benefit of those few drugs that do make it through. So what does this mean overall? It means that not only we're failing to help patients, but we're also spending a lot of money failing. If you look back in the 1940s, basically you would get 50 drugs per $1 billion spent. Now you get less than 1 drug per $1 billion spent. In fact, the Tufts Institute Center for Drug Development looked at the actual aggregate cost of pushing a new drug through, and it's $2.6 billion per drug. So imagine how many things fail, and that aggregate cost of $2.6 billion is going back to you, the consumer now, who's paying higher prices for many of these drugs. So this is really a huge challenge. We're failing to meet patients' needs, and we're spending a lot of money in that failure. Not only are we spending a lot of money and failing to meet patients' needs, but we're taking a long time to do that. If you look at the course of drug development, of how long it takes, in the preclinical realm, it's 3 to 6 years. In the clinical realm, it's anywhere from 10 to 15 years. So you can spend 15 to 20 years or so pushing a new drug through to find it just to ultimately fail. So we're wasting time, we're wasting money, and people are dying of cancer. So why does that happen? We spend so much time and money putting new cancer drugs into people. Why are we failing if we're really working hard in that preclinical space and doing all this research? And it turns out that the reason why we're failing is that drugs are either found to be not effective, so they just don't work against the cancer, or they're found to be not safe. And then you ask, okay, well, we do all this research. How can we not know after 6 or 10 years that the drug is not effective or not safe? One of the reasons is the reliance on engineered models of disease. It turns out that when we use many of these models, they're based primarily in mice. And rodent models have a number of features that make them great for research, but not necessarily great for translating back into people, which are very different than rodents. For example, most rodent studies use rodents, particularly mice, that are genetically identical. So we don't see humans that are genetically identical, typically, unless they're twins. So studying a new therapeutic in a genetically identical situation is probably not reflective of what happens in people. The other thing is that we like to accelerate tumor development because we need to get our studies done quickly. So in most of the studies that we do in mice, when we're looking at a new cancer therapy, that tumor has been engineered to grow within a week or 2 weeks, which is not the case in people. It can take decades for tumors to occur. Mice are very tolerant of treatments. In fact, how many of you knew that mice didn't vomit? They don't vomit. Horses don't vomit either. But how do you know then if a drug that you've put into mice is going to cause vomiting in people? So it's sometimes hard to assess safety in rodent models. Most rodents, particularly mice, don't sit on the couch watching reality TV, eating McDonald's, smoking, and drinking, whereas many of the people, well, not all of us, some of us do. And so they don't have complicating conditions, or what we call comorbidities, which would complicate experimental design. Many of the models that we use don't have an immune system. They're called immunodeficient. So how can you study the context of a tumor in the setting when there's no immune system? Then lastly, one of the things that ultimately typically result in death from cancer is something called recurrence and resistance, meaning you get the tumor out initially, you give them treatment, and then it eventually comes back and is refractory to treatment. And that setting is typically not used in the mouse model. So there's a lot of features of mice that are great to study biology, but really hard to translate directly into humans because mice are engineered to be experimentally valid, but people aren't engineered like that. So what does this all mean? It means that cancer is very complex, and if we don't model it appropriately, we're probably going to fail in our ability to develop new therapies. So why is cancer so complex? Well, this gives you an idea of how complex it actually looks. If you look at the inside of the ball in the middle, that's a tumor cell, and that's what signaling looks like within a cancer cell. It looks like a bunch of stuff just gone haywire. And that's what we're always trying to understand is this is sort of chaos in the middle of the cancer cell that we're trying to tease out, identify, and develop new therapies to treat. And not only are we having trouble figuring out the chaos in the middle, we're now learning that cancer cells live in neighborhoods with what we call roads, which are blood vessels, that they have neighbors who like to help them grow. These are support cells. And so they've created a whole community around them to help them grow. And now we've also learned that they engage in what we call tumor-to-tumor communication. They move material back and forth. So the bad cells are actually helping each other grow. So they have neighbors, they have roads, they have each other helping themselves grow. So it's incredibly complex and noisy. And to give you an idea of how complex and noisy it is, I'd love to use an example. How many of you saw that really awful B movie, Life, with Jake Gyllenhaal and Ryan Reynolds? Of course, nobody did. I'm the only science geek that did. So I love sci-fi, and so this one was so intriguing. It's an alien, but I should have known that Ryan was going to die immediately, in the first 10 minutes. And so I dragged a friend with me who fell asleep, and then I'm watching this thing, and so this is what the movie was about, really, and it struck me that it looked a lot like cancer. So they find this cute little organism, and oh, it's so cute, and it's growing, it's very small. It starts to get a little bigger, and then it starts to look a little scary. And then it's sending out all these tentacles. And then this is what it is. This giant organism with things that are spreading out and killing the entire crew. And eventually it gets to Earth. And I was struck in the movie, probably the only one sitting there thinking this is a lot like cancer, particularly a tumor, glioblastoma, which is incredibly difficult to treat. And this is why cancer can be so challenging. It grows, it mutates, it adapts, and it eventually kills the host. So this sounds horrible. Oh God, we're going to fail. We're never, ever going to fix this. Well, it turns out that even though it looks horrible, biology has done something really interesting that has helped us out. It has conserved things across species. So there are many patterns in biology that are recurrent. And so this gives you an example, and you just sort of follow the colors. You can see that yeast, worms, all flies, and all the way up to mammals have very similar elements that drive their biology, that help them live, that help them survive. So what we really want to do is find the signal in the noise. And I use this example because I'm heading into these years with my daughter, who's 10. And this is kind of what the bedroom looks like. You can't, where's there a floor in there? There's a bed somewhere. But you know, if you could clean it up, you would find there's a piano that we didn't know was there that could be played. So the goal in what I do in comparative oncology is to find the signal in the noise. So how do we do this? The first thing we do is we leverage cancer in dogs. So how many of you own a dog? Many of you. I bet you didn't know that cancer is incredibly common in the dog population. Spontaneous cancer, not stuff that's induced. This is stuff that just happens in our pets. And basically, if a dog lives to 10 years old, 50% of them will get a tumor. In fact, cancer is so common in dogs, it's more common on a per 100,000 patient basis than it is in humans. And it turns out that also that cancer at the molecular level looks a lot like, cancer in dogs looks a lot like cancer in humans. So what we've been promoting over the past really 10 years is a really new way at looking at drug development, which is, yes, you have to do stuff in research models. But what we'd like to do is to integrate spontaneous canine cancers into the whole drug development process, because dogs exist in the same environment that we do, that are exposed to many of the same things. Their cancers take a long time to develop, and they also vomit frequently. So you can look for side effects, et cetera. So in this model, before you ever get into people, you put a new drug into a dog with cancer, and you do tumor-bearing dog studies to see, is it safe? Can we get appropriate blood levels? Can we see any hint of activity? If the answer is yes, it gets pushed forward to people. And then while those first studies in people are being done, you move it back into the dog and you ask, how do we give it? How many days a week should we give it? Do we give it with chemotherapy? Do we give it radiation therapy? What tumor types is it best suited for? Take that information, move it forward to the human side, with the goal eventually of playing off both species so that we can optimize therapeutics when they get into people and pull those out of the pipeline before they fail. And that would save time, money, and save patient lives. So does it work? The answer is yes. This just gives you 5 examples of drugs that I've personally been involved in the development of. So these are drugs, many of which now have FDA approval, and we did the initial studies in dogs with cancer to show they were safe, effective, and helped move those projects along. There are cooperative groups now that have worked together and shown that, yes, it does work. We've been able to show that we can specifically target a novel therapeutic to the tumor. We've been able to test new immunotherapeutics. We've been able to demonstrate personalized cancer therapy works. And we've been able to take 3 drugs that look really the same and pick one out that's the best. And incidentally, in that study, the dogs picked the right one and the mice picked the wrong one. So that was a really helpful study. So how are we building this resource at Tufts? Within the Cummings School, we've been very fortunate because now we have a new renovated clinical trials office for which we could run these clinical trials. And on an average sort of month, we have anywhere between 15 to 20 clinical trials going of novel agents and novel diagnostics. And many of these are in dogs, but we're working in cats and other species as well to really help move the process forward. So this has been a huge resource that's really advanced us to the next level. Within the national setting, there are a number of resources that support this cooperative effort. The Comparative Oncology program, which is based out of the NCI, the National Cancer Institute, has been around for about 10 years and has about 21 centers now that run cooperative studies to really move the human process forward. It's a very formal clinical trials consortium, and now they have a brain tumor consortium as well that's working to help improve outcomes in brain cancer. We're very fortunate that Dean Kachiver was able to drive really a phenomenal effort to organize veterinary academic centers around the notion that we could really compete and contribute in the One Health space. She spearheaded the founding of the CTSA One Health Alliance, known as COHA, which has really taken off over the past couple of years and now has 15 academic centers that are really changing the landscape of how we do clinical trials. making sure that we're all using the same sets of standards, same reporting, connecting us all as a community to help not just improve our own patients, but help human health as well. And then lastly, the National Cancer Institute has recognized that particularly in the field of immunotherapy, we need to be innovative. And they have put money through the Cancer Moonshot into understanding canine cancer through tumor sequencing, this whole genome work it's called, as well as through clinical trials. And there was a big pot of money that was put towards translational clinical trials in immune therapies in dogs. And we were fortunate enough to get 2 of those 5 awards here at Tufts, which is really exciting. Lastly, what I really want to emphasize is none of this is done in a vacuum. We have a number of partners at Tufts now that we've been able to grow over the past couple of years that are within the Boston area. Both of them are they're academic and industry partners that are really interested in using this sort of comparative team-based approach to emphasize what we can learn across both species and optimize and advance outcomes for people. So what happens if it really does work? And this is sort of a theoretical approach. If we can really use this comparative effort to pull things out of the pipeline that are bad and push things through, you could see the orange solid line shows the number of drugs that would actually, or the orange dotted line shows the number of drugs that would actually be in the pipeline moving forward. So you'd pull a whole bunch out. Not many would be pushed through. And then you would save basically $1 billion a year by doing that, which is a huge savings that could be reinvested in research to address some of the more difficult challenges that we face. But ultimately, the thing that really matters are the people and their pets and family members. And so what I want to leave you with today is the thought that one day a dog could save your life by potentially participating in a clinical trial of a new cancer therapy that you then get or a family member gets once it's approved. Thank you.